with Dr. Sierra Windsor, MCAS specialist. Here talking about all things related to MCAS. We did 2 separate interviews regarding MCAS symptoms. We talked a little bit about lab testing for MCAS, and now we're going to go through in much more detail around how people get diagnosed with MCAS and some of the things we need to take into consideration. All right. Welcome back, Dr. Windsor.
Thank you.
Always a pleasure to see you. All right, so we talked in the last video in regards to just a brief overview of kind of diagnosis of MCAS. So why don't you walk us through kind of the criteria that is required for MCAS diagnosis in terms of the 3 sets of things you've got to meet?
Yes, yeah, so you need all 3 things, which is, we were just talking about, is a bummer. First thing is you need to have histamine-mediated symptoms in at least 2 different body systems at the same time.
So that could be like your GI tract and your skin.
Yeah, like if you have a rash and you also have bloating or diarrhea at the same time, that counts. But if you only have symptoms in one category, that does not count. So if you just have like itchy eyes, runny nose, no, doesn't count.
Or you just get like respiratory symptoms.
Exactly.
Yeah, okay.
Exactly.
So histamine symptoms in at least 2 different areas of your body.
At the same time.
At the same time.
Part 2, you have to have positive mediator testing correlated to symptoms, which is that timing we were talking about in the last video.
And that's a lab testing. So that's like a positive tryptase or histamine
prostaglandin D2 and methylhistamine in urine or leukotriene 4 in urine. Some people include chromogranin in there, but it also can be positive from lots of other things, so it's kind of messy. So you need to have a positive test when having symptoms. So they really are trying to like push like you're having symptoms and they are correlated to a histamine mediator.
Okay. And then we did the whole video previously was like how those mediators or lab markers are not easily tested and a lot of times can be normal even in people who are having MCAS flares.
Yes,
okay.
Correct.
All right. So then and what's the third thing?
Part 3 is you have to have a positive response to one of those mediator therapies. That could be an antihistamine, that could be a mast cell stabilizer, any of those.
Got it. Okay. So you have to have the symptoms in at least 2 different areas. You need to have the positive lab testing, which is, hard to get sometimes. And then you've got to have a positive response to the medication. Okay. Now, if you think somebody has MCAS or symptoms or maybe their labs are normal, what are some other conditions you might think about that might look like MCAS or similar or things you want to rule out as well?
Yeah, it's a great question. It's really important to not miss these other things, and the biggest one I usually think of is like autoimmune conditions and like the wealth of options that can happen there.
Yeah.
There can be a ton of overlap, and I've had a couple patients that like we know there's an MCAS component, but there's also like some other autoimmune components, and it's kind of like which one do you start with first? And usually if in those patients I have started with the mast cell stabilizers first, and they've felt like X amount better, but then it kind of tells you there's still something else going on in the background. So it's tricky when a lot of these symptoms can overlap from different conditions and different systems. So making sure we're also looking for those things as well.
Yeah, and some autoimmune diseases can be assessed via lab testing, some cannot. So that can also make it very challenging as well.
Yeah, it can be.
What are some other conditions that might seem similar in symptom presentation?
I mean, I think I see a lot of questions in the comments about like hereditary alpha tryptamia, which is more of a genetic condition that your tryptase will just always be high. And that doesn't mean you necessarily have MCAS, but there is a lot of overlap between those 2.
Yeah.
So I've seen that one come up a lot. And then of course, like there's the more like mastocytosis conditions, which basically means you have an aggregate of mast cells. You have too many mast cells in certain tissues, and we can find that in the GI tissues. They can find that in bones. Like it can happen in a variety of places. And to test that, you just have to do a biopsy and use a CD117 stain to look for mast cells in those tissues.
Got it.
So different than MCAS, because MCAS is like you have a normal amount of mast cells, but they're just really overactive.
And there was a lot of people asking it in the previous interviews that we did about symptoms of bone pain, which you had pointed out is not a common symptom of MCAS,
Correct.
but can be a symptom of mastocytosis.
Yeah, if your bone marrow is making too many mast cells. And unfortunately, a bone marrow biopsy is not a super fun diagnostic test to get. But if that kind of opens up a whole different world of treatment options that are very different than MCAS, so it is worth doing if that's your primary symptom.
Yeah. So that is a much bigger workup than perhaps MCAS is, because you're not getting a bone marrow biopsy when someone who has MCAS.
Yeah. Hopefully not.
Yeah, hopefully not. Okay, and then what about are there any other conditions you might think of?
I mean, there's like chronic idiopathic urticaria, like people have chronic hives that can certainly seem MCAS-y, but might also be more autoimmune mediated. So we just want to make sure we're keeping a broad differential, especially if you start treating and it's not like a magical experience. Like, like I would expect if it's mostly MCAS mediated that with a good mast cell stabilizing, a good plan, things would feel significantly better. So if they're not, right away, that's my clue to start looking, broaden the differential and look elsewhere.
Okay. What is the difference between like allergies, like an allergic presentation versus MCAS in terms of assessing for a differential?
Yeah, and that is tricky because patients with MCAS will come in with a very long list of things that they are allergic to. And it can be hard to differentiate between like, okay, what is a true allergy and what is not. And the big difference there is, for example, if you are allergic to a food like a strawberry or a potato, etc., whatever it is, every single time you eat that food, you're going to have a reaction to it. Histamine and MCAS reactions are a lot more unpredictable, meaning like one day you can eat that and be okay, and if you ate it the next day, it would not be okay because of how your body's detoxing that day. Maybe you were stressed, you didn't sleep well, like all the other things that fill up your histamine bucket and limit your detox of histamine can make you can overflow and have a reaction. So it's that predictability that is really the difference, and also why it's hard to treat.
Yeah, so you're not necessarily going to have the same reactions to a particular food over and over again. It's going to seem more nuanced. It might be more confusing in its presentation because it's dependent upon how your liver's working and like what other mediators are breaking down and all that stuff. Okay. All right, that's helpful. So we had talked in our last interview about how a majority of people who have MCAS will actually test negative on labs. And if that's part of the diagnostic criteria, what is your advice to individuals that have all the MCAS symptoms, maybe respond well to treatment, but are not getting those positive labs or confirmation that they need to say this is what's actually going on?
Yeah, and that's the tricky part, because if you have, a functional provider or someone who's willing to like work with other tools, like there's natural things that stabilize mast cells, there's so many options to see what could be a good fit, then great. But I think a lot of our viewers are in areas where they don't have access to a lot of providers outside of the traditional medical system, and a lot of those providers really do want that criteria in order to even consider talking about those medications.
Yeah.
So if I was in a position where I couldn't get access to those medications, I would explore all of the other natural tools as much as possible and just make sure I have a great antihistamine protocol on board.
And of course, potentially looking for other providers that might be willing to work a little bit outside of that scope, assuming that, that you're using safe precautions.
Exactly. Because in my opinion, if you need, multiple antihistamines and all you say 5 or 6 tools in order to manage things, and a mast cell stabilizing medication like ketotifen can replace all of those by just stopping the histamine from being released at the start and decreasing all those other inflammatory mediators, I consider that to be a safer long-term solution.
Yeah, that makes a lot of sense. And then, of course, we'll do another segment where we'll go into some of those treatments that we're commonly using, like what's the difference between a mast cell stabilizer and an antihistamine, and do people respond differently? I mean, is it always that you just give a antihistamine and everyone is like magically better?
I wish.
Medicine would be so easy if that was the case. Or is it that it's like trying a combination of things, and what are you looking for in terms of treatment response to help kind of guide what's going on? Okay, cool. Thank you.